Welcome back, guys. Today we'll continue with the clinical anatomy of the upper limb. You guys are learning about the muscles and their innervation in lab, so we'll just jump right in with some clinical situations that involve the muscles of the arm. Biceps tendonitis is an inflammation, right? Itis meaning inflammation. So an inflammation of the tendon that's connected to the biceps brachii, the muscle in the anterior compartment of the arm that's utilized for flexion at the elbow. Biceps tendonitis typically occurs at the tendon of the long head of the biceps brachii. There is a long head and a short head, right? Two heads, hence being called biceps, bi meaning two. Looking here, you can see the biceps brachii, the proximal part of it, where the two heads connect to the scapula. The short head, which you see right here, is attaching to the coracoid process of the scapula. The long head, which is what we're looking at with biceps tendonitis, it attaches just above the glenoid cavity to the supraglenoid tubercle. So it attaches right here to the scapula. But before it attaches to the scapula, the tendon of the long head runs through the two tubercles of the humerus. So the humerus has these two tubercles, or these two kind of like rounded processes that stick out, the greater tubercle and the lesser tubercle. The little groove between them is referred to as the intertubercular sulcus. So the tendon of the long head of the biceps brachii runs through this intertubercular sulcus on the humerus before it connects to the scapula. Now, when the biceps brachii contracts, when it's working, the tendon moves back and forth through this sulcus, and that can create a little bit of friction or wear and tear on the tendon. With typical use, this isn't a problem. However, with repetitive overuse, this can lead to inflammation of the tendon, hence biceps tendonitis. This is common in competitive sports that involve throwing, right? So throwing is constant use of that biceps muscle. So we see this is really common in baseball players, specifically competitive baseball players. And then the inflammation itself is associated with pain. So we just said in biceps tendonitis, there's inflammation of the biceps tendon, right? Specifically the tendon of the long head of the biceps muscle. Now, this typically happens with that muscle because of the friction as it rubs against the humerus. You guys saw that the short head didn't run through a similar groove like that, so it's not typically associated with the same amount of inflammation. So we said with biceps tendonitis, there's inflammation of the tendon. If that tendon is continually stressed, right, it's not relaxed and treated, it continues to be stressed, then that can cause the tendon to rupture, right? So we say ruptured tendon of the long head of the biceps. Rupture meaning tear. The tendon is typically torn from its attachment, its proximal attachment to the scapula, right? So we said that it's attached to the supraglenoid tubercle of the scapula. So it's the proximal attachment that usually ruptures. When the tendon of the biceps, the long head of the biceps ruptures, it's typically audible. The person hears a snap or a pop when the tendon ruptures. So they'll frequently report that they heard it when it happens. And then also, without the proximal attachment, all of the elastic components in the muscle and then in the distal tendon down here pull the belly of the muscle distally. Okay, so it's no longer anchored up here, and the belly of the muscle gets pulled down towards the elbow. So the muscle shortens and moves down distally towards the elbow, and you typically will see a ball, like a swollen bulge, near the center of the anterior arm. This is referred to as a Popeye deformity. I remember Popeye he's a cartoon. He eats spinach and all of a sudden his muscles bulge. He's a really skinny guy, but then he has this huge bulge here, where his biceps are, where his biceps muscle is. So when the muscle bulges like this, which you see right here, and this is at rest, right? Like you don't have to be flexing, just at rest, there's this bulge here. That's referred to as the Popeye deformity, associated with a rupture of the long head of the biceps brachii. The biceps reflex is one of the deep tendon reflexes that is typically tested during a physical exam. The position of the patient is just like you see here in the picture. Their arm is relaxed. It's supinated, which supination, remember, is when the palm is facing forward or the palm is anterior and the elbow is partially extended. And again, it's really important that the arm is just completely relaxed, so the patient can't be holding their arm up. It needs to be relaxed. Your thumb, or the practitioner's thumb, should be placed on the biceps tendon. This is specifically at the distal attachment of the biceps at the elbow, which again you see here in the picture. If you want to find your biceps tendon, and just put your finger here in the anterior elbow, and if you can't find it, just flex your arm. Like if you flex, then you'll feel right here. You can actually see mine, right? You can see right there, that's my biceps tendon. It's hard, you can't actually see it when my arm is relaxed, but I can palpate that very easily. So the thumb is placed firmly on the biceps tendon, and then the reflex hammer is tapped quickly at the base of the nail bed. The intent is to push firmly but really quickly on the biceps tendon. Pushing on that biceps tendon stretches the muscle, and there are sensory receptors in the muscle spindle that sense the stretch of the muscle, and the reflex is there to prevent overstretching of the muscle that would damage the muscle and interfere with function. So when we push on the tendon and we stretch it, those sensory receptors notice that stretch, and the reflex arc carries the signal up to the spinal cord. The spinal cord then sends a signal down to tell the muscle to contract, and that contraction shortens the muscle to bring it back into normal functioning range so that it doesn't overstretch. Right? So the point of tapping on the tendon is to provide that initial stretching that starts this whole reflex arc. The biceps reflex tests the integrity of the musculocutaneous nerve as well as the C5-C6 spinal cord segment. The musculocutaneous nerve is the nerve that innervates the biceps brachii. The musculocutaneous nerve, you can see right here, comes down in between the brachialis, which is the muscle you see here, and then the biceps brachii has been cut. So the musculocutaneous nerve goes down in between these two muscles. It innervates the muscles of the anterior compartment of the arm, and these are the flexors. So the biceps reflex, which again we just said involves contraction of the biceps muscle, that signal to the biceps that tells it to contract is carried via this musculocutaneous nerve. So if there's damage to the musculocutaneous nerve, this signal to contract is not going to get sent to the biceps muscle, and you're not going to see a response. This also tests C5 and C6 segments of the spinal cord. This is the area of the spinal cord that's responsible for integrating the reflex arc. This is a reflex, so it's quick and it involves minimal synapses. So it does not need to go up to the cerebrum and have all of this processing and then the signal come from the motor cortex. That does not need to happen. It's the C5, C6 spinal cord segments that again are responsible for integrating the afferent and efferent limb or efferent and efferent arm of the reflex. So a positive response is a normal response. A positive response to the biceps reflex is going to be an involuntary contraction of the biceps brachii. That practitioner, so you will feel the tendon tense. Remember, your thumb is placed right on that tendon. You'll feel it tense when the bicep muscle contracts. And there's typically a brief flexion at the elbow that creates a small jerk of the arm. Right? There's a little bit of a jerk of the forearm. There are multiple abnormal responses that can occur, and these would just indicate some sort of nervous system damage. Right? This could be damage to the spinal cord, this P5 or C6 segment. This could be damage to the musculocutaneous nerve. And abnormal responses can be excessive or they can be diminished. There can be no contraction, there can be slight contraction, or there can be excessive hyper reflex. When we talk about grading the biceps reflex, we can grade this 0, meaning no response. Two plus is actually normal. This is a normal jerk, the normal time, normal length of time. And 4 is excessive. Injury to the musculocutaneous nerve can occur because of axillary trauma or because of neural lesions. Axillary trauma that damages the musculocutaneous nerve is typically penetrating trauma. Okay, for example, from a knife wound in the axilla, or some sort of penetrating trauma in the axilla can damage the musculocutaneous nerve, which you see over here in dark blue. Neural lesions can occur typically on the lateral cord, which gives rise to the musculocutaneous nerve. And you see this up here, right? These three kind of like dark, dense lines are showing you the cords. In the lateral cord, you see giving rise to the musculocutaneous nerve. Damage to the musculocutaneous nerve results in paralysis of the flexors on the anterior compartment of the arm. So paralysis of the brachialis, the coracobrachialis, and the biceps brachii. This results in drastically weakened flexion and some interference with supination of the forearm, but drastically weakened flexion at the elbow. There's also possible loss of sensation in the lateral forearm. The lateral cutaneous nerve of the forearm relays sensory signals from the lateral forearm. Right? So the thumb side of the forearm, which you see here. And the lateral cutaneous nerve of the forearm is a branch of the musculocutaneous nerve. So if there's musculocutaneous nerve damage, obviously the signals from this area are going to have trouble getting relayed up to the central nervous system. And you see here, this is just sensory nerve distribution. And you see musculocutaneous nerve provides sensory nerve distribution to the lateral forearm or thumb side of the forearm, both anterior and posterior. Injury to the radial nerve can occur at different locations. It can occur up in the superior regions of the nerve, or it can also typically occur at the elbow. And depending on where the injury occurs, we'll have damage to different muscles in the arm. Just looking at the radial nerve to start. Okay, you see the radial nerve comes down and it wraps around the back of the humerus and then comes up around the elbow, right, the front of the elbow or the antecubital region, and comes down into the forearm. Okay, there's like superficial sensory branches over here, and then back here, this is all going to the posterior compartment of the forearm, which is primarily extensors. Extensors of the wrist and of the fingers. And this is what you see here, right? Extensor, 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 right? Supinator, extensor, extensor, extensor. Also in the upper arm, it goes to the triceps brachii. And the triceps are also extensors, right? Extensors of the elbow, not the wrist and the fingers, but they're also extensors. So biceps are flexors, triceps, extensors. So injury to the radial nerve. If it occurs superior to the branches that go to the triceps brachii, right, which were right here. So if nerve injury damage happens up toward the axillary region, then this results in paralysis of the triceps. So this means loss of extension at the elbow, paralysis of the brachioradialis, which the brachioradialis is kind of weird because it's in the posterior compartment of the forearm, but it is involved with flexion. So that's just kind of a strange one. The supinator, extensor muscles of the wrist and the fingers, which all of these are in the posterior compartment of the forearm, right, except for the triceps, which are in the posterior compartment of the arm. So this results in paralysis of all of these muscles. Also loss of sensation in portions of the lateral arm and the dorsum of the hand, which if you look back on the last slide, you'll see sensory distribution of the radial nerve. If damage happens in the radial groove, which the radial groove, let me show you. The radial groove is right here. So in the anterior elbow, like between where so looking at the distal humerus, there's the capitulum and the trochlea are these two processes here. There's a little groove that's located right in like this area between them, and that's where the radial nerve passes through. So if, like for example, if there's fracture of the distal humerus, this can damage the radial nerve as it goes through the radial groove. So in that case, the more proximal muscles, so the triceps brachii, are still innervated, they're still functioning fine. However, all of the distal muscles are now not innervated, they're not able to contract. So if damage to the radial nerve occurs in the radial groove at the elbow, then that results in paralysis of the muscles in the posterior compartment of the forearm, okay, which are these muscles that I've circled up here. So brachioradialis, supinator, extensor muscles of the wrist and the forearm. All of those. Injury to the radial nerve, the characteristic sign of this is called wrist drop. And this is what you see right here. Again, you lose the ability to extend, right, to perform extension at the wrist and fingers. Right, so here you see complete lack of extension there. The brachial artery is important for providing blood flow to the muscles of the arm. Brachial artery damage, whether it's from occlusion or laceration, interrupts blood flow to the muscles of the arm and can cause ischemia and necrosis relatively quickly. If occlusion is gradual or partial or simply temporary, then collateral pathways can preserve muscle function. Gradual occlusion building up allows time for collateral pathways to form, and then muscle function is preserved. However, if there's complete occlusion of a vessel rapidly or laceration of a vessel of the brachial artery that impairs blood flow to the muscles, this is a surgical emergency that needs to be fixed immediately because ischemia can result within just a few hours of interrupted blood flow, brachial artery blood flow to the muscles of the arm. Ischemia of the muscles results in relatively rapidly formation of fibrotic scar tissue. And this fibrotic scar tissue causes the muscles of the arm to shorten permanently. When the muscles shorten, this acts kind of like contraction, and it results in flexion of the fingers and the wrists, permanent flexion of the fingers and the wrists. We call this flexion deformity. And what you see in this picture here is a flexion deformity. And this results in loss of function of the hand. This is referred to as ischemic compartment syndrome, or also called ischemic compartment syndrome. It's referred to as well as Volkmann ischemic contracture. And the constant appearance of contraction due to ischemia. Ischemic compartment syndrome can also occur post-fracture. If there's a fracture with a lot of inflammation, the inflammation can interrupt capillary blood flow, and this causes ischemia and necrosis. So then necrosis leads to either further inflammation, which leads to further ischemia, which leads to further necrosis, and there's this whole cycle that can occur. And again, because of the inflammation, there's tons of pressure that builds up inside the fascial layers, the deep fascia of the arm. In that case, a fasciotomy allows for a release of the pressure, and that can restore capillary blood flow to the muscles of the arm. So that's a little bit different, the way that the inflammation is causing the compartment syndrome and interrupted blood flow in that situation. Occlusion of a vessel is obviously a different surgical intervention, but regardless of how it's happening, death of the muscle and fibrotic scar tissue building up around the muscle can create this ischemic contracture or this flexion deformity. Speaking of the brachial artery, right at its very end point, the antecubital area right in front of the elbow, this is where we measure arterial blood pressure. When we measure arterial blood pressure via the brachial artery, a cuff is placed around the arm, just above the elbow, and the cuff is inflated with air until brachial blood flow is occluded. As the cuff is inflated, it squeezes the arm, and the brachial artery gets compressed against the humerus. Once it's compressed against the humerus with more pressure than the blood pressure, right, more pressure than the heart is able to generate, then that completely occludes or stops blood flow through the brachial artery. A stethoscope is placed over, the bell of the stethoscope is placed over the brachial artery in the cubital fossa, which we'll learn about in a second, but just this little like triangular area here in the antecubital area right in front of the elbow. And then the pressure in the cuff is slowly decreased, and you listen for the sound of blood spurting through the artery. That sound is called the cough. Sound. So initially when you listen, you don't hear anything because the artery is completely occluded. There's no blood coming through. Then as the pressure decreases, eventually you'll hear blood comes through, stops, comes through, stops, comes through, stops. And every time you hear that spurt or that sound, that's when the heart is contracting. That's when the ventricles are in systole, right? When the ventricles are in systole, there's more pressure in the artery so the blood can push through. Right, so that the pressure, when you first start to hear the cough sound, that's the systolic pressure. Now, blood doesn't go continuously through the brachial artery because the pressure is only high enough to push the blood through when the ventricles are contracting during systole. When the ventricles are in diastole, when they're relaxing, there's not enough pressure to push past that cuff that's squeezing the artery. However, you continue to decrease the pressure in the cuff, right? So you hear spurt, 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 but eventually the pressure in the cuff is less than the pressure in the arteries during diastole, right? Once the pressure gets low enough that blood flows continuously, you won't hear the sound anymore. So when the sound stops, that pressure is the diastolic pressure. Okay? The reason you don't hear anything anymore once the pressure is lower than the diastolic pressure is that blood flow is continuous. Through the brachial artery at that point, right? The cuff isn't squeezing very hard. There's no occlusion whatsoever. The blood is flowing continuously. Here you guys see that. You can hear the brachial artery comes alongside the humerus, right? And then you see in the antecubital area, or just past the elbow, it splits into the radial artery and the ulnar artery. Over here, you see the cuff is placed above the elbow, right? So the pressure is going to be put on the brachial artery against the humerus. The split into the radial and ulnar artery is down here. Right, so you're placing your stethoscope just above that split at the terminal or towards the distal end of the brachial artery. So if you look here, you pump up the cuff until you've completely occluded the brachial artery and there's no blood flow whatsoever. And then slowly decrease the pressure in the cuff. At some point, you'll get to a point to where when the heart contracts, there's enough pressure to squeeze some blood through. And then when the heart relaxes, it's closed again. When the heart contracts, you squeeze some blood through, and then the heart relaxes, it's closed again. That first cough sound, the pressure reading at that first sound, that's your systolic pressure, right? When the pressure is able to overcome the cuff. Then you continue to decrease the pressure in the cuff, right? It goes down, 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 and then eventually blood flows continuously. Right? Whether the heart is in systole or the heart is in diastole, the blood is flowing. The pressure reading at that point, when the sound disappears, is your diastolic pressure. Right? So you get two pressure readings, say 120 over 80. Right? Your systolic and your diastolic. This first pressure is when you first hear the cough sound, and then the diastolic pressure is when the cough sound stops. And again, this is compressing the brachial artery against the humerus, and you're listening right at the distal end of the brachial artery. The cubital fossa, cubital meaning elbow, and fossa is in a little depression. So the cubital fossa is the shallow triangular depression that's anterior to the elbow, right, or just in front of the elbow. The borders of the cubital fossa are the superiorly, or the top border is the line that connects the medial and lateral epicondyles, which, remember, are little processes at the bottom or distal end of the humerus. So these on the sides of the humerus here, those are the epicondyles. So a lateral line between them. You typically in the front have an elbow crease right here. The little line or crease in your elbow is right alongside those. So that forms a nice border in the front of the arm. Medially and laterally, the borders of the cubital fossa are formed by the two muscles that you see here. The pronator teres is on the pinky side, brachioradialis is on the thumb side. The floor of the cubital fossa, or just deep to the cubital fossa, is formed by two other muscles. The brachialis forms the superior portions of the floor, and the supinator forms the inferior portions of the floor. The roof, or the top superficial portion of the cubital fossa, is formed by the area where the brachial fascia and antebrachial fascia connect. The fascia, or the roof, is reinforced by the bicipital aponeurosis. So the aponeurosis forms it goes over the top of the fascia and reinforces that roof of the cubital fossa. Above that, or superficial to the roof of the cubital fossa, we have subcutaneous tissue and skin. The subcutaneous tissue that's superficial to this cubital fossa is where we have the median cubital vein. The median cubital vein, remember, connects the cephalic and basilic veins. And these are all superficial veins of the arm. Also in this subcutaneous tissue above the cubital fossa, or superficial to the cubital fossa, we have the medial and lateral cutaneous nerves of the forearm. They tend to run alongside the cephalic and basilic veins. Here you see the borders of the cubital fossa over on this side. Again, it's a triangle. The apex is inferior, so it's like an upside down triangle. And you draw a line between the lateral and medial epicondyles. That's right where the crease in your elbow is. And then the pronator teres on the medial side and brachioradialis on the lateral side, or thumb side. The floor is formed by the brachialis superiorly. Right, so the brachialis is this muscle that, remember, is deep to the biceps brachii, and then the supinator inferiorly. The roof, right, we can't see because it's been torn off, but the roof is formed by the brachial fascia and the antebrachial fascia, which would form a sleeve, remember, over the muscles in the arm and in the forearm. This is showing us the subcutaneous tissue that lies over the cubital fossa. Again, in this subcutaneous tissue that lies over the cubital fossa, this is where we have our superficial veins, as well as our cutaneous nerves. So looking at the veins here, this is the median cubital vein. Okay, so the median cubital vein runs right through or right over the surface of the cubital fossa. And then the cephalic vein is right here, and then the basilic vein is over here on this side, the pinky side. Here you see the contents of the cubital fossa. So we've pulled the roof off and we can look down into the cubital fossa. The biceps tendon you see going right through the middle of the cubital fossa. This is the biceps brachii right here with the muscle. And then here in white at the end you see, let me change colors. Right here you see the biceps tendon. Looking at this, this is the medial side, or the pinky side. And then over here is the lateral side, the thumb side. So starting in the middle and moving towards the medial side, we go from the biceps tendon, and then directly next to that, the brachial artery. And this is the terminal, or the very end of the brachial artery, right before it splits into the radial and ulnar. So you can see that. You see the brachial artery coming right here. And then you see it splits. And the radial artery is going towards the thumb side. So this is the radial artery. And then the ulnar artery is over here. coming towards the pinky side. You also see the median nerve. So the median nerve comes through the cubital fossa right next to the brachial artery. So median nerve is by the brachial artery. So all of those, that starts from the middle and going towards the medial side. In that row, you have the biceps tendon, the brachial artery, and then the median nerve. If you look laterally or towards the thumb side, you see the radial nerve, and then its superficial and deep branches, which that makes sense. The thumb side is the radius side, right? So the radial nerve goes by the radius. And here you see this over here. So the radial nerve comes into the cubital fossa, and then shortly after it enters, it branches. And we have its deep branch, and then its superficial branch. Coming up here. Notice the ulnar nerve does not go through the cubital fossa. Okay, the ulnar nerve, you notice just right over here, right? But it's not dipping down into the cubital fossa. Here you can see some of the more obvious surface anatomy of the arm. Just starting with the muscles, the deltoid is clearly visible. The deltoid is this kind of triangular shaped muscle that's present in the shoulder. The biceps brachii is also visible, right? Biceps brachii is in the front of the arm. Biceps, the deltoid. The triceps brachii is in the posterior portions of the arm. You can see the lateral head bulging right here though, and then most of the back of the arm would be the long head, and then inside is the medial head. The brachioradialis is typically pretty easy to see as the larger bulge of the forearm right here on the thumb side of the forearm. The flexor carpi radialis and flexor carpi ulnaris are the muscles of the forearm on either side. So ulnaris is the muscle on the pinky side, right? And flexor carpi radialis is the muscle on the thumb side. Those are a little bit harder to actually see, but the tendons are easy to pick out. So if you look over here, the easiest tendon is the palmaris longus tendon, which is in the very center, going down to the center of the palm. So like if you make a fist and tighten up, kind of flex your fist like that, you should be able to see the palmaris longus, and then on either side, the flexor carpi radialis is on the thumb side, and then on the pinky side is the tendon for the flexor carpi ulnaris. Looking at the vessels, the superficial veins are typically easy to see. The cephalic vein is going to come down kind of in the middle of the biceps brachii, which you see here. It kind of curves in some at the elbow, and then the cephalic vein comes out towards the thumb side. So if we look over on here, these two arrows, I'm showing you the cephalic vein. So you see it comes down the biceps, kind of comes in a little at the elbow, and then down the thumb side. The basilic vein, the basilic vein comes in down the pinky side, so it's more medially here, and all the way down the pinky side. So it would come in here more medially, and then down over here. Coming across the cubital fossa, across the elbow right here, that's the median cubital vein. So if we look over at this guy here, his cephalic vein is coming down the bicep. It comes in and then goes out down the thumb side. Basilic vein is coming more medially and comes all the way down the pinky side. Connecting them is the median cubital vein. Again, where we normally get blood drawn. You can also see the median vein of the forearm here on him. Looking at the hand, which we'll talk about the hand a little bit later, but the thenar eminence is this large kind of bulge at the base of the thumb, and then the hypothenar eminence is on the other side of the palm beneath the pinky. I'm looking at the digits. The thumb is the first digit, and then 2, 3, 4, and the pinky is the 5th digit. Okay, palm of the hand, and then the back of the hand would be the dorsum of the hand. Both the biceps tendon and the triceps tendon can easily be palpated. We already talked about the biceps tendon when we talked about the biceps reflex, but just in the cubital fossa, right, so in the front of your elbow there, you can palpate the biceps tendon pretty easily with the arm flexed at 90 degrees. It's harder when the arm is straightened, but if you flex the arm to 90 degrees, you can palpate that biceps tendon. If you put resistance on the arm during flexion, you can palpate it even easier. The triceps are in the back of the arm, so the triceps tendon is in the back. The triceps tendon connects to the olecranon. The back of the elbow, remember that this large kind of bulge at the back of the elbow is where the olecranon is. So just superior to the olecranon, you can palpate the triceps tendon. Again, if you're having trouble doing it, just flex the triceps. The triceps are used for extension. So if you put resistance against the arm and have them extend it, you'll be able to easily palpate the triceps tendon. So again, this process right here is the olecranon. The triceps tendon is just superior to it. We do muscle testing on a couple of the flexor digitorum muscles. Here you see testing of the flexor digitorum superficialis. The flexor digitorum superficialis is in the intermediate layer of the anterior compartment of the muscles. So anterior compartment right off the bat tells you that the muscle is probably involved in some sort of flexion. Looking over here, you see the muscle. Again, it's in the intermediate layer or intermediate, so like the middle layer of muscles, the forearm. And you can see that it wraps around the ulna, right? So it's kind of wrapping around the ulna here a little bit. And then looking at the tendons, you see that the tendons connect to the middle phalanges. Okay, so we have metacarpal bones here in the hand, and then proximal, middle, and distal phalanges. The flexor digitorum superficialis attaches to the middle phalanges of the 2nd through 4th digits. The flexor digitorum superficialis is utilized to flex the wrist, to flex the metacarpal phalangeal joint, right? Like so this movement. And then also to flex the proximal interphalangeal joint. So we've got 2 interphalangeal joints, proximal and distal. So the proximal interphalangeal joint is between the proximal and middle phalanx. This is the joint where we typically test the muscle, and here you see the way that we test it. So the fingers are held flat, right? They're held extended, and one of the fingers, you ask the person to flex that finger at this proximal interphalangeal joint, and typically it's against resistance, which you see there. Right? So the joint is this joint right here, and ask them to flex it against resistance. Here you see the muscle testing of the flexor digitorum profundus. The flexor digitorum profundus you see here, again, also around the ulna. but in this case, it's in the deep layer of the anterior compartment. So the flexor digitorum profundus sits deep or just underneath the flexor digitorum superficialis. The flexor digitorum profundus connects, as you see here, it connects to the distal phalanges. So it's also utilized to flex the wrist, but in addition to flexing the wrist, instead of flexing the proximal interphalangeal joint, it flexes the distal interphalangeal joint, right? So here, that's the area between the middle and distal phalanx. So just this last joint here, the little tiny tip of the finger. So to test it, the proximal interphalangeal joint is held extended, right? So the finger is held straight here, and then the person flexes their distal interphalangeal joint again against resistance, which you see here. Elbow tendonitis, right? So inflammation of the tendon of the elbow, or it's also called lateral epicondylitis because there's inflammation around the lateral epicondyle on the thumb side of the elbow. Occurs when there's repetitive use of the superficial extensor muscles of the forearm. So these are in the posterior compartment of the forearm. And these muscles are used to extend the wrist. So repetitive, forceful extension of the wrist, which is really frequent during tennis. So this is also referred to as tennis elbow. And this strains the attachment of the common extensor tendon, right? The tendon that attaches these extensors to the lateral epicondyle. So this results in tendonitis or inflammation of the common extensor tendon, as well as inflammation of the lateral epicondyle, again at the elbow. Pain is typically felt over the lateral epicondyle, but then it radiates down the posterior forearm. Tears of the common extensor tendon are common with elbow tendonitis, and these tears can be seen on an MRI and are repaired surgically. Here you guys see the elbow joint where the tendons are attaching to the lateral epicondyle. Just looking at the elbow right here, you see the medial epicondyle, and then deep to these muscles right over here would be the lateral epicondyle. So here's the common extensor tendon as it attaches to the lateral epicondyle, and this is where all of the inflammation is occurring, and then that pain radiates down the posterior areas of the forearm. The wrist is a common site for the development of a synovial cyst, or a cyst that develops in conjunction with a synovial sheath. These are also referred to or it's called a ganglion. They are typically non-tender cysts of the hand, again, most frequently on the wrist. They're thin-walled, filled with clear mucinous fluid. The most common site is on the dorsum of the wrist in conjunction with the synovial sheath, specifically at the distal attachment of the ECRB tendon. ECRB is extensor carpi radialis brevis. So at the tendon, the distal attachment of the tendon of the extensor carpi radialis brevis. So the dorsal side of the wrist is the most common site, and you'll see like a swollen little ball, and typically it's non-tender unless it enlarges to a point to where then it does start causing pain. But on the dorsal side of the hand, it's typically not associated with serious complications. On the anterior side of the wrist, however, it can start to compress nerves and become associated with more serious complications and be associated with more pain. For example, a cyst that's related to the common flexor synovial sheath can enlarge and end up narrowing the carpal tunnel. Remember, the carpal tunnel is the little space or tunnel where the median nerve passes through. So a narrowing or stenosis of the carpal tunnel can end up compressing the median nerve. Compression of the medial nerve causes something called carpal tunnel syndrome. We'll talk more about carpal tunnel syndrome in a second. This is just one of the things that can lead to carpal tunnel syndrome. But again, this is when the cyst is on the common flexor synovial sheath on the anterior side of the wrist. Dorsal side of the wrist does not end up compressing the median nerve. Here you see a typical ganglion or a typical synovial cyst. Again, on the dorsal side of the hand. Here, this is showing you the carpal tunnel. Here you see the carpal ligament stretching from the carpal bones on either side of the wrist. And then the little passageway that it creates through here is the carpal tunnel. So you see all of the tendons that are passing through, and then also the median nerve. So a cyst that grows in conjunction with this tendinous sheath, right, that you see circling around the tendons, can then compress the nerve if it enlarges enough, and then you have carpal tunnel syndrome result. So carpal tunnel syndrome, again, just occurs when there's something that narrows the carpal tunnel, and this compresses the structures that pass through the carpal tunnel, really specifically, or most importantly, the median nerve. We just saw that a cyst of the synovial sheath on the anterior side of the wrist could grow into the carpal tunnel and lead to carpal tunnel syndrome. This can also occur because of any inflammation or lesion that occurs in the carpal tunnel, decreasing the size of the tunnel. Again, the cyst is when a structure in the tunnel increases in size. And then again, that can also decrease the available size of the tunnel and compress the structures within it. Compression of the median nerve. This compresses the two terminal sensory branches that supply the hand, specifically the regions of the hand that I've circled here. This results in paresthesia or tingling, anesthesia, lack of sensation. It can result in pain in the lateral 3.5 digits. So again, the area that I've circled here. The thumb, remember, is more lateral. So 1, 2, 3, and then the lateral side of the fourth finger, the ring finger, are areas where symptoms occur. Also, compression of the median nerve compresses the one terminal motor branch, the recurrent nerve, that innervates the 3 thenar muscles. The 3 thenar muscles are responsible for the thenar eminence, this large area or kind of swollen ridge at the base of the thumb. So that results in wasting of the thenar eminence, and then also thumb weakness as well. Okay, so pain, tingling, numbness, in the lateral 3.5 fingers of the hand, of the affected hand, and then also wasting of the thenar eminence, weakness in the thumb. This is common in people who do repetitive work with their hands and wrists. So typically associated with people who work at a computer all day, who are typing at a computer all day like this, or people who hold vibrating tools that require good grip strength. They're constantly stressing the tendons that go through the carpal tunnel, and that causes inflammation in the area. Inflammation in the carpal tunnel can then compress the nerves that run through it, specifically, again, the median nerve. There are a couple tests that we use to test for carpal tunnel. One of them you see right here. This is called Phelan's test. For Phelan's test, you compress both of the wrists at 90-degree angles, or flex the wrists at 90-degree angles, and hold that for a period of time. Some texts say 30 seconds, some say 60 seconds, but a positive result is when there's numbness and pain and tingling in the lateral 3.5 fingers of the hand that you're testing, or both. Another test involves percussing the distal wrist crease over the area where the median nerve passes through the carpal tunnel. So that's what you see happening right here, percussing the wrist crease. And if symptoms appear, so numbing, tingling in the lateral 3.5 fingers, then that's also a positive sign pointing towards carpal tunnel syndrome. Carpal tunnel release is a surgical procedure that's done to relieve the pressure in the carpal tunnel and then relieve compression of the median nerve that passes through the tunnel, as we see with carpal tunnel syndrome. There's a complete or partial division of the flexor retinaculum, which is the same thing as the transverse carpal ligament, which stretches across the top of the carpal tunnel. So by dividing the ligament, you relieve the top or kind of roof on the carpal tunnel, and that allows you to relieve pressure and compression of the median nerve. The incision is made to the medial side of the midline, so closer to the pinky side. The reason for this is that the median nerve passes down pretty close to the midline of the carpal tunnel. And then also the recurrent branch of the median nerve is this branch that comes right over here to innervate the thenar muscles. So the recurrent branch is on the thumb side or lateral side. And it innervates the thenar muscles of the thumb. Motor innervation to the thenar muscles. And we don't want to cut through that recurrent branch or damage that recurrent branch nor the median nerve. So by making the incision just laterally or just to the pinky side of midline, you avoid the median nerve and the recurrent branch. Here you see the compartments of the hand, and there are different muscle groups in each of the different compartments. So right off the bat, there's a thenar eminence and a hypothenar eminence. These are like the raised areas on either side of the palm. So the thenar eminence is this area underneath the thumb where the thenar muscles are. And then on the pinky side is the hypothenar eminence, where the hypothenar muscles are. So the compartments are named the same, right? So in blue, you have the thenar compartment, and that's where the thenar muscles are. In green, the hypothenar compartment, where the hypothenar muscles are. The adductor compartment has the adductor pollicis, in the adductor compartment, which is here in purple. The lumbricals are in the central compartment. Umbilicals are in the central compartment, which is here in the very center of the hand, the center of the palm. The interossei. So interossei are in the interosseous compartments. So here, these are the interosseous compartments, and those hold the interossei muscles, and they're both dorsal and palmar. Interosseous muscles. These interosseous muscles, the dorsal and palmar interossei, those are between the metacarpal bones. So the metacarpal bones that are enclosed in the hand, you can see here, are on the sides of the interosseous compartments. You can also see the septa, the medial fibrous septum right here, and the lateral fibrous septum towards the thumb. And then the digits, we've already learned to name the digits or number the digits, but the digits are 1 through 5. Number 1 is the thumb, and 2, 3, 4, and the pinky or little finger is number 5. Tendonitis is inflammation, so itis meaning inflammation, of a tendon and a synovial sheath. Inflammation of the tendon and the synovial sheath of the digits occurs when there's a puncture wound to the finger that results in infection of the synovial sheath. So this is punctured by something that's dirty. It happens a lot with rusty nails or some sort of dirty tool in people who work construction or work outdoors a lot. So infection in the digital synovial sheath or the synovial sheath of the fingers results in inflammation of the synovial sheath as well as the tendon that's running through it. The 2nd through 4th fingers have tendons with separate synovial sheaths. So 2nd through 4th would be the pointer, middle, and ring fingers. And if you look here, you can see this, right? Their sheaths are separate. So infection in one of these or tendinosynovitis in the 2nd, 3rd, or 4th finger is typically limited to that finger. It typically does not spread beyond the finger unless it goes untreated and the infection fulminates, and there ends up being so much inflammation and pressure that it ruptures the proximal end of the sheath, right? So rupturing the proximal end of the sheath would allow for the infection then to spread into the mid-palmar space or the space between the thenar eminence and the hypothenar eminence. The synovial sheath of the little finger or the 5th finger, you guys can see here, is continuous with the common flexor sheath. So this would allow the infection to spread from the little finger through the hand, through the carpal tunnel, and into the forearm. So this is important to be aware of the differences if somebody has a rather dirty puncture wound in the pinky versus in the 2nd through 4th fingers. Quervian tenovaginitis stenosis, or it's also called Day Quervian syndrome. Quervian tenovaginitis stenosis. Teno like tendon, vaginitis like passageway, stenosis is a narrowing. So a narrowing is the passageway that the tendon is going through. The tendons of the abductor pollicis longus, right? So abduction, this is going to the thumb, longus, long, and the extensor pollicis brevis are in the same tendinous sheath on the dorsum of the wrist. specifically the lateral or thumb side of the dorsal wrist. And you can see this here, right? These are sharing tendinous sheath that comes down to the thumb. Excessive friction of these tendons in the synovial sheath or tendinous sheath results in a fibrous thickening of the sheath. As the sheath thickens, that causes stenosis, right? Or narrowing of the osteofibrous tunnel that the tendon is in. This narrowing causes more inflammation, which causes pain. The pain occurs in the dorsal lateral side of the wrist, and this typically radiates in both directions. It radiates proximally up to the forearm, and then also distally out to the thumb, which we said these tendons were on the lateral side or extending out to the thumb side. Finkelstein test is a test that we use to test for de Quervain syndrome or Quervain tendovaginitis stenosis. The patient puts their thumb in the hand, right? So the thumb is enclosed in the fist, and then they abduct or pull push the wrist away from the midline. And when you do that, you can see that you would stretch these tendons right here, right? And stretching these tendons right here causes pain if de Quervain is present. So looking for pain that radiates down the thumb or the forearm in that area when the movement is done would be positive sign that points towards de Quervain syndrome. Here you guys can just see, again, just in a little bit more detail, the abductor pollicis longus, this is the tendon right here, and then the extensor pollicis brevis, this is the tendon right here. So you can see how these come down, right? And then eventually again connect onto the thumb. Here you can see this is the osteofibrous tunnel, right? The passageway that the tendons pass through, and inflammation in the area causes a fibrous thickening, or stress in the area causes a fibrous thickening that narrows the tunnel. That causes further inflammation and pain, and this is just showing you Finkelstein test. Digital tendovaginitis stenosis, or it's also, instead of stenosis, it's also called stenosans. But again, we're looking at a narrowing the passageway that the tendon passes through, in this case, digital. So we're looking at the fingers. This is also called trigger finger, not trigger finger, but trigger finger. It's relatively common, but the tendons of the flexor digitorum superficialis, which the flexor digitorum superficialis, remember the tendon comes and inserts on the middle phalanx, and the flexor digitorum profundus, which the tendon inserts on the distal phalanx. Both of these tendons run through the same osteofibrous canals, and they share sheaths as they pass up through the fingers. When there's an enlargement of these tendons, a nodule can form, and the nodule forms just proximal or just before the osteofibrous tunnel, and that's what you've seen happening like right here. So you see the tendon coming, right, and then there's a nodule right here, and then here's our nice tunnel. And the nodule is so large that it doesn't slide into the tunnel nicely. It doesn't slide through nicely as it should when the muscles are contracting, pulling on the fingers. So you're unable to extend the finger. And as you try and extend the finger, the tendon would normally come through into the tunnel. But this nodule is blocking the tendon from sliding in through that tunnel. So the finger is stuck like this, right? Like trigger, like when you pull on a trigger. That's why it's called trigger finger. And if you extend the finger, right? I'm sorry, I'm doing that. I mean to like bend it more. If you extend the finger, then it's a popping sound, like an audible pop, as the nodule is forced into the osteofibrous tunnel. And this can actually happen. It's shown here at the metacarpal phalangeal joint. It can occur at a more distal joint as well. Trauma or damage to the median nerve most frequently happens at the wrist. The reason for this is just the location of the median nerve at the wrist. If you look, the median nerve is located really close to the surface. It's extremely superficial at the wrist, so lacerations to the wrist can end up damaging the median nerve. Damage to the median nerve results in paralysis and wasting away of the thenar muscles. The thenar muscles, remember, are in the thenar compartment at the thenar eminence, this large bulge at the base of the thumb. And then also the first two lumbrical muscles. So because of the wasting of the thenar muscles, there's an emaciation of the thenar eminence, right? This wastes away here. Also, you lose the ability to oppose the thumb, right? Which opposition is moving this way, right? And then reposition is moving it back. So you lose the opposition movement. And then also it interferes with fine movements of the second and third digits because of the damage of the first two lumbrical muscles. There's also a loss of sensation over the first 3.5 digits. That's the area that the median nerve is responsible for carrying sensory input from, right? So the thumb, the pointer, the middle finger, and then part of the ring finger is the first 3.5. You do still have sensation though in the very middle of the palm. So this picture is just a little bit misleading. Trauma to the median nerve can also occur at the elbow, so it's not just at the wrist. It happens most frequently at the wrist, but it can also occur due to penetrating trauma at the elbow. If the median nerve is damaged at the elbow, you have a loss of flexion of the proximal and distal interphalangeal joints of the second and third digits. So proximal and distal interphalangeal joints. These are the knuckles and the fingers. Okay, so this is the proximal interphalangeal joint. This is the distal interphalangeal joint. So loss of flexion at the proximal and distal interphalangeal joints of the second and third digits. So the pointer finger and middle finger. Also loss of flexion at the metacarpophalangeal joints of the second and third digits. So the metacarpal phalangeal joint is from the metacarpal to the proximal phalanx. So that's flexion here and here. And then also inability to oppose the thumb, as well as what we saw on the last page, right? You're damaging the nerve higher up, so you're also interfering with like sensation of the first 3.5 digits as well. Ulnar nerve injury can again occur at multiple different areas. It can occur at the elbow, the wrist, or the hand. The most frequent area or the most frequent location of ulnar nerve injury is at the elbow, specifically posterior to the medial epicondyle, right? So the epicondyles are these little bulges on the distal, humerus. Okay, so just behind the medial epicondyle right here is where the ulnar nerve passes through. So that's the most common place that it's damaged. Damage to the ulnar nerve results in extensive motor and sensory loss in the hand. The wrist is typically drawn laterally during flexion, So when the wrist is flexed, it's drawn towards the thumb. So there's no straight flexion. There's also difficulty making a fist because you can't flex the fourth and fifth distal interphalangeal joints and cannot extend the interphalangeal joints to straighten the fingers. So can't fully flex the hand and then can't completely straighten the fingers either. So this results in a deformity that's called claw hand. Looking at the ulnar nerve. The ulnar nerve, again, we said is damaged when there is, or it's typically damaged at the medial epicondyle. So the epicondyle on the pinky side, you can see here that the nerve passes just behind the medial epicondyle and then passes down the side of the ulna. Here again, you can see passing down the arm medially by the medial epicondyle. Here you see the motor branches going to the flexor carpi ulnaris, the flexor digitorum profundus, and then continuing down, and then there are tons of branches in the hands, right? So the intrinsic muscle of the hand, including the loaf muscles. Loaf muscles are the lumbricals, opponens pollicis, abductor pollicis, and flexor pollicis brevis. Okay, so again, huge loss of motor function in the hand. That's why it results in the claw hand deformity. Here you see sensory innervation to the hand. So ulnar nerve on the side of the ulna, which is the pinky side. So sensory loss is on the pinky side.